Welcome in. I'm your host, and today, I'm shifting into full clinical instructor mode. We're tackling a topic where the absolute stakes literally could not be higher, both for your future patients and for passing your NCLEX. We're talking about psychiatric pharmacology. Now, we are not just casually reviewing medications today. We're mastering the high-yield, life-or-death clinical alerts that the exam absolutely loves to test. So grab your notes, put away your phone, eliminate all distractions, and let's get bulletproof. Okay, let's dive right into a seriously lethal scenario. What happens if a patient accidentally mixes a selective serotonin reuptake inhibitor, like fluoxetine or sertraline, with a monoamine oxidase inhibitor, like phenelzine? Well, the answer is a highly dangerous, potentially lethal synergistic effect known as serotonin syndrome. To prevent this, the exam requires you to know without a doubt that a strict washout period of 2 to 5 weeks is absolutely mandatory between stopping an MOI and starting an SSRI or buspirone. You cannot simply switch these medications overnight. I want you to go ahead and pause this explainer right now to memorize this foundational information. Notice how SSRIs like fluoxetine and SNRIs like venlafaxine target serotonin and norepinephrine to elevate mood. Then, think about the older classes. Tricyclic antidepressants, or TCAs, like amitriptyline, work by blocking the reuptake of neurotransmitters. And finally, MAOIs block the destruction of neurotransmitters by the MAO enzyme. Understanding these exact mechanisms is how you're going to predict the severe adverse effects we're about to cover. Now, let's talk about the pharmacokinetics of the TCA amitriptyline. The big thing to notice is the delayed onset of action, 7 to 21 days. This delayed onset is highly testable. But what's even more critical for the exam is that TCAs are notorious for potent anticholinergic adverse effects. We're talking severe dry mouth, constipation, blurred vision, urinary retention, and, most dangerously, dysrhythmias. An overdose on a TCA can cause lethal cardiac events, so basic life support and antidysrhythmias are absolutely your priority interventions. You've got to commit this next clinical alert to memory. When a patient, especially a child or an adolescent, starts an SSRI like fluoxetine or sertraline, the first 4 to 6 weeks are the most dangerous. Why? Because the medication actually gives them their energy back before their mood fully lifts. This means they now have the physical energy to carry out a suicide plan. You must constantly assess for suicidal ideation, covert thoughts, and sudden changes in mood during this incredibly vulnerable window. So, what's the big takeaway with MAOIs? If you fail to teach your patient about this specific tyramine-free diet, you are putting them at risk for a deadly hypertensive crisis. And these restrictions are strict. We're talking aged cheeses like Swiss and blue cheese, draft beer, dry sausages like salami, and even over-the-counter cold and flu products are strictly forbidden. If a patient on an MAOI eats a salami sandwich with Swiss cheese and starts complaining of a severe headache or tachycardia, you are facing a massive medical emergency. All right, it's time to test your knowledge. Go ahead and pause the explainer right now and battle your way through this first NCLEX gauntlet on antidepressants. Answer these 5 hard questions and meticulously read the rationales. Don't move forward until you can explain exactly why an SSRI and an MAOI cannot be mixed and exactly what foods trigger a hypertensive crisis. Welcome back. Let's shift gears and talk about anxiolytics. We're going to directly compare benzodiazepines like diazepam, lorazepam, and alprazolam with a really unique drug called buspirone. Benzos work by enhancing GABA, which is the primary inhibitory neurotransmitter in the brain. They cause immediate, heavy sedation. Buspirone, on the other hand, is completely different. Its exact mechanism is unknown, it lacks the sedative and dependency properties of benzos, and, critically for the exam, it must be administered on a strict schedule. Never PRN. Now, benzodiazepines are generally safe on their own, but they become incredibly dangerous, even lethal, when mixed. If a patient combines a benzo with alcohol or barbiturates, they're at an extreme risk for respiratory depression and death. Furthermore, because of the sedation, ataxia, and confusion they cause, they're a major fall hazard for older adults. And if you have a patient who is unresponsive from a procedural sedation overdose, the exact antidote you must pull from the crash cart is flumazenil. Seriously, memorize that drug name. You know the drill. Time to pause and face the anxiolytics gauntlet. Hold yourself accountable here. If you missed the question on flumazenil or the GABA receptor mechanism, you need to go back and review. Your patients are counting on you to know the difference between a scheduled, non-sedating anxiolytic and a rapid-acting CNS depressant. Let's take a quick breather. You are doing fantastic work.
If you're serious about crushing the NCLEX and want more high-yield, no-nonsense clinical reviews just like this one, make sure to like this explainer and subscribe to the Nurse Crush It YouTube channel. We are here to help you get that passing score. Okay, let's get back into the heavy-hitting pharmacology.
All right, back to the heavy hitters. This next topic brilliantly illustrates why mood stabilizers demand your absolute respect. We're talking about lithium. The therapeutic range here is razor thin, 0.6 to 1.2 millimoles per liter. The very second that blood level creeps above 1.5, your patient crosses into severe toxicity. Because this margin of error is practically non-existent, continuous laboratory monitoring of serum lithium levels every 3 to 4 days during initial therapy is non-negotiable. So, how exactly does a patient accidentally cross into that toxic territory? Pay close attention to this physiological link. Lithium is a salt, and the kidneys process it alongside sodium. If your patient becomes dehydrated or develops hyponatremia, which is low sodium, the body will literally hoard the lithium, leading to rapid lethal toxicity. This means you have got to teach your patients to maintain consistent fluid and sodium intake, and be incredibly wary if a provider orders a thiazide diuretic. That depletes sodium and will aggressively spike those lithium levels. If that toxicity does hit, what are you looking for? Rapid fire these clinical manifestations into your brain right now. Coarse tremors. Note the word coarse, not the expected fine tremors. Severe GI upset, slurred speech, profound muscle weakness, and poor coordination. If a patient on lithium presents to the ED with slurred speech and a coarse tremor, you do not just pass it off as fatigue. You immediately draw a serum lithium level. Hit pause right here. It is time to battle through these 5 lithium-focused questions. Make sure your understanding of the relationship between low sodium and high lithium is rock solid. Read the rationales carefully before moving on. Okay, home stretch. Let's see how all this builds into our final and honestly heaviest module, antipsychotics. We divide these into typical agents like haloperidol and atypical agents like clozapine and risperidone. Typical agents are older and fiercely block dopamine, which controls the symptoms but causes severe movement disorders. Atypical agents block both dopamine and serotonin, which generally improves their adverse effect profile. But as you'll see in just a second, they carry their own massive clinical warnings. When a patient is taking a typical antipsychotic like haloperidol, you have got to be on high alert for severe neurological adverse effects. Extrapyramidal symptoms and tardive dyskinesia involve very distressing involuntary movements of the body and face. But the absolute medical emergency here is NMS, neuroleptic malignant syndrome. If a patient on haloperidol suddenly spikes a massive fever and their muscles become entirely rigid, they are in a life-threatening crisis requiring immediate critical care intervention. Now, what's really interesting is that while an atypical agent like clozapine might save a patient from those severe movement disorders, it introduces a totally different life-threatening risk. Clozapine can cause severe agranulocytosis, which is a massive drop in white blood cells that practically destroys the immune system. Because of this, strict weekly white blood cell count monitoring is an absolute requirement. If a patient on clozapine reports a simple sore throat, a mild fever, or just feeling unwell, you must report it immediately. It could literally be fatal. All right, the final gauntlet. Don't skip this. Pause the explainer and tackle these 5 questions on antipsychotics. Completely solidify your mastery of NMS, extrapyramidal symptoms, and that strict lab monitoring required for clozapine. Read every single rationale provided. You made it to the end of the masterclass. We've covered lethal washout periods, vital antidotes, razor-thin therapeutic ranges, and critical blood monitoring. So I'll leave you with this provocative question. Are you truly ready to walk into that testing center and crush this exam? Or will you let a simple slice of Swiss cheese or a mild case of dehydration trip you up? Review these concepts until you are completely bulletproof. Keep studying hard, and we'll see you in the next explainer.